you can share with your colleagues the link. So during this webinar, please type your questions on the Q&A chat box. I'm sure all the speakers are going to be more than happy to answer you. And in the end of after the 4 talks, we are going to have a good discussion where these questions can be answered live as well. But please, during the webinar, please place your questions on the Q&A chat box. So today we have this very special meeting to talk about updates on fetal cardiology, and we are very happy to close our year in this way with such important topic and such amazing speakers. We are very happy with that. And after, when we finish this webinar, we are going to have our well-deserved vacation. And we want to thank all of you in my name, in the name of Sasha, in the name of Gil. We want to thank all the speakers who were able to give their times and their expertise for free to all our attendees. We want to thank all the 80 delegates that we have all around the world that are helping us on this task. And we want really to thank all of you for attending the webinars and for sharing this information with your team. And we know that with all of that, we are reaching a lot of countries. We had more than 125 countries that already attended our webinars, and we are really, really happy and proud of it. And I'm happy to say that the best is yet to come. We have a lot of things planned for 2021. Please, if you have any ideas or if you want us to do a particular activity, please don't hesitate to text us or to send us one email to tell about your ideas. We are going to be very happy to consider that. So now, Sasha, you can introduce the organizer of this very nice webinar and one of the speakers.
So thank you, Grace, and thank you very much to all the people who is connecting to us in 2020. I think that was an amazing year, and I'm sure we can do better all together. But today we want to finish when the life start from the fetal cardiology, from the fetal echocardiography, what I think is amazing tools to improve the level of assistance in congenital heart disease. So it's my real big pleasure to introduce Professor Rima Bader, who is the Professor of Pediatrics and Pediatric Fetal Cardiology at the King Abdulaziz University Hospital. He's also advisor of the Ministry of Health in King of Saudi Arabia. He's the founder of the Fetal Cardiology Service, again in Saudi Arabia. She's a lot of things. I'm sure she can tell you more from herself. And thanks to all the speakers. It's a pleasure to see all of you today with us. Thank you. And Rima, it's your time.
Thank you very much, Sasha and Grace and Dr. Gansky for such a beautiful effort in the Congenital Heart Academy. I had the pleasure of organizing this fetal webinar because I feel that people need to know more from the world eminent speakers in both fields, in perinatal and fetal medicine. So we have Dr. Lisa Hornberger. She doesn't need any introduction. She's very well known in the field of fetal cardiology. She used to be my mentor many years back and a co-author of our well-read handbook of perinatal cardiology. And with Dr. Huta, she's currently based in Canada, Alberta, and leading lots of programs, lots of educations, lots of education. And also on board, we have also my ex-mentor, Dr. James Huta, based in Florida. Dr. Huta is very well known for all his novel work in hemodynamics of fetals and specifically the cardiovascular profile score that we most of the time use in the assessment of the well-being of the fetal heart. And it's a sort of an honor and pleasure to have my two ex-mentors talking and teaching the world the beauty of fetal cardiology.
Lisa, I think you
Dr. Ahmed Abu Hamad, he's joining us as well. Grace, do you want to introduce Dr. Abu Hamad?
Yeah, I think when I say at the time of his talk, we can do this. So let's start with Lisa. Okay. We are very happy to have you here, dear.
Great. Thank you so much to the organizers, to Rima, Sasha, Grace, Gil, and the rest of the Congenital Heart Academy. It's my pleasure to be giving this lecture. I'm quite excited about participating in this event. And it's a little early, and you can see behind me the beautiful Northern Lights, which is not too far from us here in Alberta. So my talk's on fetal cardiac function in clinical practice, what we do and what we don't. So assessment of fetal heart function, sorry about that. My thing is a little bit slow. It's probably too early in the morning. So assessment of fetal heart function is a critical element of fetal echo in the context of primary cardiac and extracardiac disease. It impacts the fetal heart for extracardiac disease that impacts the fetal heart function. There are many tools and methods available to assess function of the fetal heart, but really what requires consideration is what most adequately defines systolic and diastolic function, what is or are sufficiently sensitive to permit early detection of myocardial dysfunction, and should be used for routine versus lesion-specific assessment. So for systolic function, and I put a list of possible values and measures that we can use. Probably what we most use day in and day out are a basic eyeball qualitative assessment of the fetal heart squeeze. As you can see here, really simple. You can see both ventricles squeezing quite nicely. But we also can use shortening fraction, ejection fraction, DBDT, but it requires high velocity AV valve regurgitation, long axis function, ataxia, MAPSI, stroke volume, cardiac output, S prime tissue velocity, isovolemic contraction, isovolemic acceleration, and systolic strain or strain rate. And the ones that are bolded in blue are what I consider sort of the basics. So here's one that we're all very familiar with postnatally. This is assessing the shortening fraction from either M mode, sliced through a short axis of the fetal heart with the RV and LV shown here. You get a tracing that looks like this. This is great from a temporal resolution standpoint. And what you're seeing is end diastole and end systole, and we can use this equation to calculate our shortening fraction. I prefer actually personally to do it using, I've got to turn off my phone, sorry, using a 4-chamber image, but you have to come at it kind of in an image that's axial to make sure it's accurate. And normally you get a shortening fraction of 34 plus or minus 6%, and most are less than, more than 28%. So 28% is a good cutoff. It doesn't change with gestation, similar for LV and RV, and it's simple and familiar. You can also calculate ejection fraction. We do not do this for a number of reasons, but you can use biplane Simpsons and other algorithms to generate an ejection fraction. It's been validated in animal models based on the work of Klaus Schmidt and Norm Silverman. And ejection fraction is roughly 66% plus or minus 4%. It's similar for both the LV and RV, and it's constant through gestation, but it's time consuming, difficult to reproduce, and you got to have good images that can give you sufficient images for tracking or tracing. You can also calculate ejection fraction using 3D and 4D methodologies. The strength is that it permits calculation of EF, stroke volume, and mass. These are, some of them are automated, and that makes it a lot quicker. You get numbers that aren't too different from what's been generated using other methods. There's reportedly good inter and intra observer variability. The problem is a lot of us don't have the equipment to do this. We don't have the experience, and it sometimes can take a bit of time, especially if you're one who hasn't done a lot of this. Long axis function, tricuspid and mitral valve annular plane excursion. There have been a couple reports out there from the UK. This is the tricuspid valve, and you get a tracing by M mode that then allows you to map out diastole and systole, and you're looking at the difference between the two. And there is normative data generated for this for LV and RV. The strength is that it's simple and there's little time involved. The only problem is the LV doesn't really function as much in its long axis. It's much more circumferential, and so it's not the best for that, and it's load dependent. We also will use stroke volume and cardiac output, especially if there's any concern that either there's a risk for increased cardiac output or increased like sort of a high output state, or reduced cardiac function, and looking at where the outputs are relative to normal. This is measuring the stroke volume with the cross-sectional area of the valve itself, multiplied by the VTI from the Doppler tracing. And there we can then calculate the cardiac output of stroke volume times the heart rate. And this is just showing you the measurement of the valve in systole, aortic valve and pulmonary valve, and then you're doing your VTIs. And there's quite a bit of normative data that has been calculated or generated over the years and published. This is one by Resenin, published in Circulation. And you can track what normal outputs look like. You can also do this by volume techniques, and there's some data also generated and published in the literature by several groups. The problem with these simple techniques of systolic function assessment, all are impacted by loading conditions. So preload and afterload absolutely affect these values. Many require adequate alignment that you may or may not get from this fetus, because often the fetuses do what they want, somewhat like teenagers. Some are not good for RV, such as the shortening fraction and ejection fraction, where the geometry is sort of assumed, and that's not going to necessarily be true for the RV, and others the LV. So as an example, MAPSI, as I mentioned, LV doesn't typically function as much on its long axis. It's much more circumferential versus the RV, which does function on its long axis. And most are insufficient for more complex congenital heart disease because they make certain geometric assumptions. Most require good image quality. Some require specialized equipment, as mentioned, 3D and 4D, and expertise and time. Some are difficult to reproduce, and most are insufficiently examined in complex congenital heart disease. So little data to say this is what you need to do for a specific condition in particular. So we'll go to this sort of more advanced functional techniques at the end of looking at the basics. Diastolic function, what do we use? Most of what we use are Doppler flow patterns, which are kind of our traditional approach, ventricular inflow, systemic and pulmonary vein flow patterns, isometric relaxation time. Tissue Doppler parameters have increasingly been used with annular velocities and the use of EDE prime. Color M mode propagation of velocity has been used, but there's very little data. There's very little data actually in the setting of congenital heart disease and myocardial disease. And then diastolic strain rate. And again, there's very little data. So with respect to filling patterns, we're all fairly familiar with this biphasic inflow with an E during early ventricular diastole and A during atrial systole. And we find in the EDA waves, measuring those and also the duration of inflow can be quite helpful. One can see in the context of severe myocardial disease, you often will get a foreshortened or a fairly shortened duration of inflow, and often use uniphasic. For many, it may just be an A. This is actually from a baby with confirmed restrictive cardiomyopathy, where it's a big E, very little A, and short duration of inflow. So these are the findings that you see in the context of myocardial disease or ventricular dysfunction. But one must understand that there's an evolution of these patterns in normal fetuses with gestation. So in the very early first trimester, one can see that it's a uniphasic and very short duration inflow, much like what we see in bad disease at 30 weeks or 40 weeks. At 14 weeks, it becomes biphasic, but you can see the E waves quite short, and then so on. You get progressive E wave increase and very little change in your atrial systolic velocities. And this is what you see. Peak E goes up. A for this particular paper did not change at all, and E to A prime as a consequence goes up. So you can also use your inflow-outflow on the LV side to assess your isometric relaxation, another measure of diastolic function. What's interesting, this also changes with gestation. So you look at that's the interval from the offset of outflow to the onset of the inflow. And what is important is it does change with gestation, being quite high in the first trimester, progressively decreasing, and then kind of plateauing, although some papers suggest there's a slight increase to term from the mid into the third trimester. Normal in the mid to third trimester should not be more than 45 milliseconds. I've seen some report 35 milliseconds as a cutoff, but at least not higher than 45 milliseconds. And it has been shown to be prolonged in many cardiomyopathies, Ebstein's and early twins, suggesting decreased possibly relaxation, but I think there's probably different elements of diastole that may be impacting this. And it's been shown to be shortened in restrictive cardiomyopathies. AV duration, your inflow duration, progressively increases, particularly in that first trimester, and then somewhat plateaus relative to the RR interval, the cardiac cycle length. So that's also important. And then you should have a normal value that is between 0.15 and 0.2 relative to the RR interval through the remainder of gestation from the mid-trimester. And this actually coincides with decreasing IVRT and IVCT, isobolic contraction time, both of which are quite prolonged early in gestation and go to almost zero, very, very low measures as you get beyond about 11, 12 weeks. So systemic venous Dopplers are another measure that we will routinely actually look at. A normal IVC flow pattern, or hepatic vein flow pattern, shows a peak in systole, a smaller peak in diastole, and early diastole, and then a tiny little A-wave reversal that's both of short duration and short velocity, usually never greater than 20 centimeters per second is sort of a good cutoff. Of note, though, very early in gestation, you have patterns that look like this, which are also patterns we see later in gestation in babies who have evidence of high filling pressures of the heart, with big A-wave, increasing A-wave velocities, sometimes increasing A-wave duration, and eventual loss of early diastolic forward flow in those systemic veins. Eventually, the worst have this sort of to and fro flow pattern. You can imagine this would be terrible for a fetus who relies on low downstream pressures, for cardiologists much like a Fontan, and relies on them actually for oxygen delivery because it's coming up from the ductus venosus. Pulmonary vein flows can also be used. So you normally do not have a wave reversal during atrial systole. It's either cessation of flow or a reduction in flow velocities. Whereas with increasing LA pressure, whether that be from a restrictive atrial septum in a left heart obstruction or myocardial disease, you can often see a reduction in early diastolic flows, increasing atrial flow that's retrograde, and eventual severe pathology. This is more so in the context of critical left heart obstruction with no egress or little egress from the left atrium. Ductus venosus flows biphasic with a little reduction during atrial systole, other than the first trimester where it can in fact hit the baseline or even go below prior to 10 weeks. The umbilical vein, which is nice and low flow velocities, sometimes undulating with fetal breathing, but when you have high central venous pressures, you start seeing a reduction again in early diastolic forward flow in the ductus venosus and increasing A-wave reversal. In the umbilical vein, you can get to as bad as UV pulsations, and of course this is very, very bad situation for a fetus who's reliant on forward flow from the umbilical vessel to provide oxygen. Global function can also be assessed. This is a really crude measure, but TAE index, or myocardial performance index, MPI, where you take the onset or the offset of one inflow to the onset of the next inflow. We use that to measure A versus the LV outflow, which is the ejection time, the onset of the ejection to the offset of the ejection. And the measure of A minus B over B is a measure of kind of global function. What it basically is the isobolic relaxation time plus the isobolic contraction time over the ejection time. And of course, as you see more disease, you might see an increasing IRT. If there's decreased function, for instance, you might see increasing ICT, so that number goes up, and your ejection time may actually, in fact, go down. So there are measures that have been published, some of which show, again, a slight increase, and others no significant change through most of gestation, other than the very first trimester. So this is just an example of its use in severe Ebstein's with fetal demise or development of hydrops, where many years ago we showed that LV-TAE index, this is Noburo and Amura, LV-TAE index was significantly higher in those that did not do well versus those that did. But it's also been shown in cardiomyopathies, twins, recipients, tetralogy of flow, absent pulmonary valve. The limitations of these more traditional parameters are that Doppler flow signals, SF, EF, cardiac output, are the consequence of myocardial function. That includes systolic contraction, diastolic relaxation compliance, but they're also influenced, again, by loading conditions, preload, afterload. Blood flows in vessels as well are very much impacted by what's upstream and downstream. So one really has to be cautious in how these are interpreted. And of course, at the end of it, they're also impacted by electromechanical events. An example is isobolic when you're looking at things like AV intervals, isotopic contraction times, part of that, the AV intervals, PR, and the isotopic contraction time measures are going to be very hard to assess in that you just don't know what the electromechanical events are doing. So not perfect, but they're easy, so we use them daily. But there are newer, well, maybe not so new anymore, echo techniques that we apply postnatally that have certainly gained increasing interest prenatally, and that includes tissue Doppler imaging, speckled tissue and feature tracking. They've given us tools to further our understanding of fetal cardiac function. I'm hoping to give you a little taste of that, and offer measures that may be more readily assessed for some and less load dependent for others. And they can be used irrespective of geometry, but they still have not really made it to prime time or routine practice. So tissue Doppler is used to assess both diastolic, systolic and global function with measures of TE or MPI. And these are E prime or EA, which is early diastole, A prime or AA. Also an E to E prime has been used, as we'll mention, and then other measures. There are several published papers that have defined normative data with acceptable reproducibility, and they can be performed down to as low as 13 to 14 weeks. So here's your E prime, your A prime, and your S prime, very low velocities. Color TDI permits post-processing, and we've used it for arrhythmia assessment, but also allows for regional wall motion and velocities offline, measures of T index, also isotopic acceleration time, which is considered a load-independent parameter of systolic function, shown here, and strain rate from Doppler velocity data. So this is one paper that I thought was kind of interesting, Harada and colleagues back in in 2005 from JACE, where they looked at isotopic acceleration measurements. And these are very hard, and interestingly, there's little to no data in fetal pathology not actually reproduced, but what they showed was it increases with gestation, suggesting increasing contractility of the fetal heart with gestation. Similar to E and A waves, you'll see that your E prime, A prime have quite similar changes with gestation, with E prime of the RV and LV increasing, A prime or AA not as much, and as a consequence you see an increasing E prime to A prime ratio. That's happens from the mid-trimester and even the late first trimester to term. ED prime in adults and children correlates with LV and diastolic pressure. In the normal fetus, ED prime exponentially decreases, as you can see here from this work of Ni et al., to about 25 weeks and then plateaus. So this suggests that maybe there are higher filling pressures at these very early stages. Hard to be 100% sure, but that's what has been suggested, and it's thought that this reflects acute changes in perhaps elements of compliance and relaxation of the fetal heart. Unfortunately, this hasn't really been used much with pathology. This is one study that looked at primary cardiac causes of high drops and showed ED prime to be significantly higher relative to normal fetuses shown in black and those with growth restriction. They also showed that S prime tended to be lower in these same babies. Probably this has not really been shown in a lot of pathologies. I thought this was kind of interesting. Tissue velocities have also been, myocardial velocities have also been used to look at who can they predict who's going to have two ventricle outcome following aortic valve dilation. And in this study, they showed that E prime was greater among those that ended up having two ventricle outcomes versus those that did not, and wondered whether this could be used for patient selection. And then they certainly showed significant improvements in many of the variables after intervention. So tissue velocity assessment limitations requires alignment for accurate peak velocities. Peak systolic velocities are load dependent. Tethering and translational motion mean that you're actually never reflecting necessarily true myocardial velocity of contraction in that context. And measurements differ from one ultrasound system to the next, which is really problematic when you're publishing normative data. And then finally, we really need to use this more with cardiac pathology. So finally, myocardial deformation strain rate provides opportunities for assessment of global and regional systolic function, less so diastolic. There's not a lot of data on diastolic function use of strain and strain rate within this context, and dysynchrony. It's three-dimensional, so this deformation is three-dimensional. It's longitudinal, circumferential, radial. Radial has been less used in fetuses, and I think it's because it's hard even to do in our postnatal patients, but longitudinal and circumferential, there's increasing data in the literature. Techniques available include color TDI, which is terrible. I'm not going to even talk about that. It's much harder to reproduce, much more difficult to do. Speckle tracking and vector velocity imaging are the ones that most people are using, especially BVI. It's fairly easy. The benefits are that they are considered less load-dependent measures of function, probably not perfect though. They're not affected by translation of motion or tethering to adjacent segments. And at least for the speckle tracking and vector velocity, they're not so angle dependent for a lot of the systolic measures. So speckle tracking relies on identifying patterns of grayscale within small regions and how their motion varies through the cardiac cycle, looking at the lengthening and the shortening of the myocardial fibers. And usually, so strain is systolic strain would be end diastole to end systole, the measurement of how much there's the reduction in the fiber length would be systolic strain. And this can be used to examine, then strain rate is basically the temporal derivation of strain. Can be used to examine global, regional, longitudinal, circumferential, and rotational function. There's a little bit of data on rotational function, but with lack of ECG gating, we must rely on fetal AV valve motion to define the cardiac cycle, which is not perfect. And then you need high frame rates really to be getting sufficient data. So there are many studies that have come out looking at strain and strain rate using speckle and tissue tracking. With reasonable inter and intra-observer variability. Interestingly enough, a few studies have suggested that the earlier weeks of gestation provide worse inter-observer variability. There's documented normative changes of circumferential and longitudinal systolic strain as well as regional strain. This study happened to show myocardial circumferential and longitudinal strain to be fairly constant through gestation and increase only after birth, whereas strain rate slowly decreased with gestation. Again, very little data, unfortunately, for diastolic function. We've used a lot of vector velocity imaging in our assessments. This uses speckle and feature tracking to obtain myocardial motion data from stored 2D images. It's really lovely because you can go back over past studies of more rare conditions. It measures peak velocity, strain rate, and displacement. The limitations are that many of the studies that you're going to go back to review have been saved at low frame rates. So stored images are often around 30 frames per second and often insufficient because you lose temporal detail. And the values by BVI have been shown to be less than values compared to TDI and other speckle tracking assessments. You can see a lot of variability as well. This is one of the limitations. So wide confidence intervals reported for normative data. The other issue is that at greater than or equal to 30 weeks, especially for circumferential strain, you find, and this is actually here, or the 30 weeks, you find less success. But there's data published suggesting there's good inter and inter-observer variability, and normative data has been published. So the issue is that tracking of acoustic markers in the fetal heart can be difficult due to its small size, fast heart rates, variable scanning depths, and no ECG gating. It really requires time and experience, can be a little labor intensive. The worst of it, though, is that there's significant variability in reported normal fetal strain and strain rates, including trends. And this actually was published out of John Simpson's group, showing 4 different studies and how strain looks. So for one, it significantly increases. For others, it slightly increases. And for yet others, it stays fairly constant. And this has been a real problem for us in really applying what normal data is out there. This variability is in part due to differences between ultrasound equipment and software among vendors. And I always say ugh to this. Anyways, but we have learned something, and different programs and different groups have looked at various different lesions to better understand how this could be applied, how these technologies could be applied, and how much they can tell us about the pathophysiologies with respect to cardiac function. So this is a normal RV. This is a single ventricle RV. This is actually an Epstein's LV. giving you some sense. But there are publications with respect to structural heart disease, twin-twin transfusion, and maternal diabetes in the literature to date. We actually used it to understand how the single ventricle adapts and then how Ebstein's don't adapt. This is work that Paul Brooks had done many years ago with our group, looking at vector velocity imaging, and we said, how does the single ventricle adapt and survive? How does it result in good cardiac output and maintenance of a relatively healthy fetus? What we found is both the single RV and the single LV became increasingly more spherical, and this was likely probably to reduce some of the wall stress. It's the way it fills. They were also filling more so by atrial systole. We demonstrated increasing short axis function or circumferential function, as you can see here, increasing radial displacement, and it was actually short axis function, as well as increasing width or diameter. And interestingly enough, in hypoplastic left heart syndrome, we found that the RV had decreasing longitudinal strain, and yet the normal RV in a healthy fetus and in postnatally functions off its more longitudinal axis, not its circumferential. And we were interested in that the single RV seems to adapt in a way that is like an LV, where the LV tends to work more so through its circumferential function. We said, well, how does this apply to our Ebstein's? Because Ebstein's have been notoriously recognized as having low cardiac outputs before birth. And in the most severe end, where there's retrograde ductal flow, all of the flow has to be redistributed to the left heart. And we said, well, how does that left ventricle adapt? This is just showing you how odd the tracking is in these left ventricles of the bad Ebstein's. We found that longitudinal strain did not significantly look different relative to the PIVS or controls. Some of them were decreased, and in fact, what we've now found is in neonates, if you've also got decreased longitudinal strain, your outcome is very poor. And then that's in contrast, the circumferential strain, we had control here. The PIVS did not look different from the controls, but Ebstein's were substantially reduced. So here's a single ventricle, basically, that should be functioning through its circumferential element, and it can't. And this, we think, actually is associated with the poor output of many of these babies. We further went on to show that there's dysynchrony both in the fetus and the newborn, but this is just showing you a synchronous single ventricle versus a very, very dysynchronous LV in Ebstein's. And you can see this beautiful synchrony as shown with our tracking versus this chaotic dance. It is not a pretty one. It's like the odd person out on the dance floor doing some really strange stuff. It's a very chaotic dance, and as a consequence, we were able to demonstrate clear, very, very significant dysynchrony, especially in the worst end of those cases and worst end of the spectrum of Ebstein's, suggesting that dysynchrony may be an element of the poor function and probably contributes to worse outcome for Ebstein's anomaly than for other single ventricles. So in summary and truth, all of our current methods of assessing systolic and diastolic function in the fetus have their limitations. Many of these routine measures, as well as tissue fetal heart function, as well as tissue velocities, are load dependent, and Doppler-based measures are also potentially impacted by heart rate. Still, their simplicity and familiarity facilitate their routine use in screening, so they are what we maybe do more routinely. But other modalities for function assessment, including tissue Doppler, 2D speckle, and feature tracking, show promise and provide insight into pathophysiology of fetal heart disease. But understanding the strengths and limitations of these techniques is critical in their application. They are what we don't do, say, in routine practice, but ongoing research initiatives will assist in determining the role of these newer techniques in clinical practice and for specific cardiac lesions. With that, I'm going to end. Thank you very much for your attention.
Thank you, Lisa. It was really, really amazing. Thank you very much for that. And now we are going to have Dr. Abu Hamad. He's not here. He sent his recording, but he's going to join us for the questions in the end of the session. So all of you can wait for him, and he's going to participate on the discussion. So Dr. Alfred Abu Hamad currently serves as professor and chairman of the Department of Obstetrics and Gynecology, director of the Maternal Fetal Medicine Fellowship Program, and vice dean for clinical affairs at Eastern Virginia Medical School. He was the past president of the Society of Maternal-Fetal Medicine, Society of Ultrasound in Medical Education, Perinatal Quality Forum, and the American Institute of Ultrasound in Medicine. And he's going to talk to us about the fetal venous system.
I am going to talk to you now about the systemic approach to the evaluation of the fetal venous system. And my name is Alfred Abu Hamad from Eastern Virginia Medical School. So during this lecture, I'm going to review the normal fetal venous anatomy. I'm going to share with you a stepwise approach to the evaluation of the fetal venous system. And I'm going to review some major venous abnormalities that are relevant to the discussion today. I'm going to focus this talk on the systemic venous system, as the pulmonary venous system will be covered elsewhere. So my goals that by the end of this presentation, I would hopefully have you look at the normal venous anatomy with a more critical eye, and that you will have the knowledge to enhance detection of venous abnormalities, and would take that information to really allow you to be able on the detailed ultrasound examination to suspect the presence of these malformations. So briefly, the embryology of the fetal venous system, the systemic fetal system, you see that we have a parallel system to start with. We have right and left superior cardinal veins and right and left inferior cardinal veins. We have right and left umbilical veins and right and left vitelline veins. And we go from a symmetrical system like this, pulmonary veins not shown here, to an asymmetrical system where there are anastomoses and obliteration of vessels to result in a system like this. And if you look at the anatomic features, you will see that looking at the venous system, you have the umbilical veins connecting with the ductus venosus in the liver, the portal veins also, inferior vena cava, the hepatic veins, coronary sinus, the four pulmonary veins draining into the posterior wall of the left atrium, the azygous vein draining into the superior vena cava, and the brachiocephalic vein. So I will be covering normal and abnormal anatomy of the systemic venous system with the exception of the pulmonary veins today. First, the inferior vena cava. I think it's important to note that the axial view of the abdomen at the level of the abdominal circumference plane clearly will show the IVC in cross-section on the right side and the descending aorta on the left side, as you see in this grayscale image. Very important plane to really establish abdominal situs should be part of your basic ultrasound evaluation as you look at the abdominal circumference plane. If you go inferiorly, so from inferior to superior, if you take a plane in the pelvis, compare it to a plane at the level of the abdominal circumference, you see that the IVC is more posterior as you go close towards the pelvis. And then it moves into a more anterior level and further anterior as you go up into the abdomen. So keep that in mind, that if you're in a lower plane where you see the kidneys, the IVC is much closer to the aorta than it is at the abdominal circumference plane. This is an important article that we reported on several years back that I will be following with regards to the systemic approach to the evaluation of the fetal venous system. So it's be important for you to review as part of your more comprehensive evaluation of the normal and abnormal anatomy. So what is the stepwise approach? You have the axial planes in the abdomen where you can actually see both the portal and the hepatic systems. You slide up to the base of the four-chamber view. You see the coronary sinus at that level. Slide up some more to the four-chamber view. You see the two inferior pulmonary veins coming in. A slight angular towards the fetal left side will show you the azygous vein draining into the superior vena cava that we call the azygous arc, as you see right here on the autopsy specimen. And then if you go up in the chest, in the mediastinum, you'll see the brachiocephalic vein, which is the inferior border of the thymus gland here. And then a parasagittal plane will show you the superior and inferior vena cavas coming together into the right atrium. What I will be covering today primarily is the portal and the hepatic system, coronary sinus as it primarily relates to the persistent left superior vena cava, the superior vena cava issues here, and the brachiocephalic vein. So let me start with the venous portal system. The concept of a portal system, there are two portal systems in the body. These are veins that don't go towards the heart. There's the hypophyseal portal system, where the vein that goes from the hypothalamus to the pituitary, and the hepatic portal system, which is a vein that goes from the GI tract to the liver. So let's look at the liver vascular anatomy first, as it is really critical in our understanding of normal and abnormal venous anatomy. So you have the descending aorta, gives rise to the hepatic artery, and the hepatic artery in adults contributes to about 25% of the blood flow coming to the liver. Then you have the splenic veins, the pancreatic veins, the gastrointestinal veins, superior and inferior mesenteric veins. They join together, as you see in this schematic drawing, to form the main portal vein that enters the liver and divides into the left and right portal vein. And that contributes about 75% of the blood coming into the liver. So the blood coming to the liver is 75% from the portal vein that's coming from the splanchnic venous plexus, and 25% from the hepatic artery that comes from the descending aorta. Now, the drainage of the liver is to the IVC from three main hepatic veins. So you have the right, middle, and left hepatic veins that join together to enter the inferior vena cava. So that's the drainage, and that's the blood supply on this side. And here you see a schematic drawing of the right middle, left middle, and right hepatic veins coming into the inferior vena cava. So if you look closely at a sagittal view of the fetal abdomen and chest here in color Doppler, you see the relationships of the portal vein and the hepatic vein. So here's the portal venous system is at this plane. This is the plane of the abdominal circumference, as you see right here. And you have, this is the umbilical vein coming in into the liver and giving rise to the portal system, as you see right here. And I'll expand a little bit on the anatomy of the portal venous system. The hepatic venous system is in a plane that is a little bit more superior, is just subdiaphragmatic. And as you see right here, you see the left hepatic vein, which is the largest in the fetus of the three. But you see them on this axial view. You see the right, middle, and left hepatic veins coming to the IVC. So note the relationship anatomically of the portal vein and the hepatic vein. They are both connected by the ductus venosus that links the two. So the ductus venosus shoots a little bit upward towards the IVC, the subdiaphragmatic vestibulum here, and links the two systems together, as you see. So let me talk about the portal and the hepatic circulation. So here again, as I mentioned, when you look at axial planes, you have the plane that is at the level of the abdominal circumference, where you see the umbilical vein coming in and the portal venous system, and a plane that is a little bit more superior, where you see the hepatic veins, as I just demonstrated in the sagittal plane. Now, what happens in the fetus is, compared to the adult circulation, is that the umbilical vein comes into the liver and actually connects with the left portal vein. The left portal vein has three branches, inferior, superior, and medial branches. And then this becomes the portal sinus right here, which is part of the left portal vein, gives rise of the ductus venosus, and then ends up in the right portal vein, which has two branches, anterior and posterior. The main portal vein is still connected to the liver also. So you have two blood supplies now. In addition to the hepatic artery, you have the umbilical vein bringing the majority of blood through the liver, connecting with the portal system. And you have the main portal vein that is not as active in the fetus because the GI tract is relatively dormant. So the blood flow comes in this direction and then mixes with the blood coming from the main portal vein towards the right hepatic, the right portal vein system. So the IVC, the aorta still provides blood through the hepatic artery, as we've discussed. And the drainage is still the same as the adult with the 3 right, middle, and left hepatic veins. Now, let me expand a little bit here. So what you will see is you have the umbilical vein again, getting to the left portal vein. And the left portal vein has these 3 branches. And if you look, here's the left portal venous system. That includes the portal sinus, actually. The right portal system right here. And the main portal system is right here. So these are the 3 important left, right, and main portal system coming in. And we showed you the blood flow in the direction that we talked about. So what you see on ultrasound is the following. So here's the umbilical vein coming in, branches of the left portal venous system right here, 1, 2, and 3, inferior, superior, and medial. You have the ductus venosus coming offshoot right here. And this is the right portal venous system with the anterior and posterior branches. Okay. Ductus venosus seen right here as an offshoot from the portal sinus, which is part of the left portal venous system. The main portal venous system, sometimes you see it, sometimes you don't, depending on the orientation of the ultrasound plane and also depending on the anatomic connection of the portal vein with the portal sinus, but it's typically around this location right here. It will be coming with blood flow going towards the portal sinus and has the superior and inferior, all the splanchnic veins that we talked about. And again, here's a still image showing you what we talked about before. Now, the hepatic system is in a plane that is a little bit higher, subdiaphragmatic. And here clearly you see, and let me just go back to show you. Here you see the left, mid, and right hepatic veins coming to merge at the inferior vena cava, as you see right here. So if you do 3D ultrasound, you see the 2 planes together. It's the umbilical vein with the ductus venosus, posterior to the right, middle, and left hepatic veins draining in the subdiaphragmatic vestibulum at this level right here. So that's the normal anatomy of the portal and hepatic venous system in the liver. Now, let's go through some abnormal findings. So first, these are the lists that I will go through: persistent right umbilical vein varix. We talk about agenesis or abnormal connections of the ductus venosus, portosystemic shunts, intrahepatic part of the IVC, and others. So let's start with the persistent right umbilical vein. So what are the clues to the diagnosis here? And you see here a movie clip of that. So the left portal vein and the sinus turns to the left side rather than the right side. So they turn to the stomach rather than turning to the right side of the abdomen away from the stomach. So that should be your first clue to the presence of a persistent right umbilical vein. And 2, the gallbladder is seen kind of under that curve. So it is to the left of the left portal vein, as you see right here. So these are the clues to the diagnosis again. And here's another case showing you a persistent right umbilical vein and the gallbladder under. So this appears to be a normal variant when it is isolated. In a large series, 75% had normal outcome, and the remainder is indicator of other associated abnormalities. So when we see a persistent right umbilical vein, we do a detailed ultrasound to look at any other associated abnormalities. And if we don't see any other associated abnormalities, we are usually reassuring the patients of the good outcome associated with this finding. The second is the umbilical vein varix. An umbilical vein varix is defined by a dilation of the intra-abdominal extrahepatic umbilical vein. So before the umbilical vein right enters the liver, it's dilated, as you see right here. There's aliasing typically within that, as you see here. There are some criteria for diagnosis if it's more than 9 millimeter or more than 50% of the intrahepatic segment of the portal vein. And clearly you could see here, we usually don't measure, subjectively assess the presence of dilation. What is the importance of this? There is a correlation with fetal growth restriction and demise, especially for large sizes. I think it's really important to do a detailed ultrasound examination here to rule out any other associated abnormalities. We usually follow pregnancies as such with the ultrasound for fetal growth and assessment of the vascular system every 3 to 4 weeks to ensure that there are no other growth abnormalities associated with that. Here's another one that is much larger than the one that we saw. You can see the size of this one and significant turbulence. These are the ones that are more concerning than a mild dilation. And here's the one you need to make sure you don't have a cardiac effect related to that. Now, another major aspect of abnormalities at the level of the portal and hepatic venous system are connections of the umbilical vein. So this is the normal connection of the umbilical vein. The umbilical vein comes in, goes through the liver, remember, as the portal vein, and then the ductus venosus connects with the IVC and the hepatic vein at the subdiaphragmatic vestibulum right here. You can have agenesis of the ductus venosus. You can have the ductus venosus that goes straight into the IVC, as you see here. You can have an absence of the ductus venosus and the umbilical vein connecting with the IVC. You can have the umbilical vein connecting with either the coronary sinus or straight into the right atrium, or you can have the umbilical vein goes into the pelvic vasculature and from there draining back through the IVC to the heart. So various connections. Here's some examples in ultrasound images. Here's a normal connection of the ductus venosus. Agenesis of the ductus venosus connecting to the IVC. The IVC connecting, the umbilical vein connecting straight to the IVC without a ductus venosus. Here, the umbilical vein going straight to the heart without a ductus venosus. And this is a very enlarged IVC because the umbilical vein is connecting through the pelvic vessels and returning blood that way. Now, what is really important to note as you look at the ductus venosus and the sagittal planes is to note the direction that the ductus venosus has. So here's the umbilical vein like this, and the ductus venosus actually angles towards the heart. Important feature to look at because that is a normal appearance of the ductus venosus going in. Why this is important, especially in the first trimester, there is some associated abnormalities, especially in the first trimesters with trisomy 13, 18, trisomy 21, monosomy X and Noonan. So let's keep that in mind. And also there is some association with fetal growth restriction when you see these abnormalities later on. So it's important to follow those pregnancies with ultrasound evaluations. Now, let me go through the portosystemic shunts, which is a significant important finding prenatally. It could be hard to make the diagnosis. Hopefully, I will share with you some clues to help achieve that. So a portosystemic shunt is a direct connection between the portal veins and the systemic veins bypassing the liver. So that's the simple diagnosis. They could be extrahepatic or they could be intrahepatic. So here's extrahepatic. You have the type 1 where the main portal vein connects with the IVC and no portal venous flow comes into the liver. That's the complete type of portosystemic shunts. There's the partial portosystemic shunts where there is a connection between the portal vein and the systemic veins, as you see right here, and there is some blood that comes to the liver as part of the portal venous system. These are extremely difficult, if impossible, to diagnose prenatally. This is easy to diagnose because you don't have any portal venous system in the liver. This is really extremely, I don't know if there's any cases that have been diagnosed prenatally of such, but these are the definitions. Now, let's go to the, this is the one that is complete type, where the portal vein goes to the IVC bypassing the liver. And when you look on ultrasound, what you will see is the following. So you will have an abdominal circumference at the level, plane at the level of the abdominal circumference, and color Doppler, you only see the hepatic drainage and you don't see any portal venous system. So that's the clue to the diagnosis. Complete absence of portal venous system on ultrasound. Absence of blood flow, liver in the liver. The partial one, as we talked about, is there is a maintained intrahepatic portal venous system and there is reduced blood flow to the liver. Again, I believe very difficult to make the diagnosis prenatally. Now, the intrahepatic type of the portosystemic shunt, here in this example, you have the left portal vein connecting with the left hepatic vein, as you see right here, directly. Typically what happens, the portal vein goes into the liver, and the blood drainage from the liver goes through the capillaries back into the hepatic veins. Here, there's a direct communication, kind of like an anastomosis, if you will, between either the left or the right portal vein to the hepatic veins. So what are some clues to diagnosis? Direct connections. And what you see, for instance, is a dilated, when you have a left portal vein connecting to the left hepatic vein, there's a dilated left portal vein and a dilated left hepatic vein. And you see color Doppler aliasing and a dilated hepatic artery related to that, because there is increased blood flow from the artery now coming to the liver because of the lack of blood flow from the portal. So here's the umbilical vein coming in. Look at the size of the superior and inferior left pulmonary veins draining into what looks like a space right here. And that is actually where the direct communication, and in blue is the large left hepatic vein also draining. So dilated branches of the portal and the hepatic veins in the liver. And here you see the portal veins, inferior, superior, and the hepatic veins as such. Here's another example, again, in another fetus with a fairly similar, you could see on grayscale, the dilated branches, and look at the left hepatic vein dilation here. And you could see on color Doppler, the left hepatic veins, and in red here, the two branches of the left portal veins. And here's another one that is really significant. And here you could see the connection. You could see like a lake type space within the liver. And on color Doppler, you see the branches coming in significantly dilated, connecting with the hepatic system. Now, the hepatic artery could on occasions be dilated, as you see right here, because there's increased blood flow now coming from the hepatic artery, from the aorta to the liver, because of the lack of blood supply, because of this communication. Remember, in the normal adults, 25% of the blood coming to the liver comes from the hepatic artery. In the fetus, the most of the blood coming to the liver comes from the umbilical vein through the portal venous system. When the portal venous system establishes an anastomosis and does not bring blood to the liver, there is an adjustment from the hepatic artery increasing blood flow to the liver. Okay, so the clues to the diagnosis on the right side are similar: dilated right portal veins and hepatic veins, and color Doppler aliasing, as you see here. So this is a right portosystemic shunt. In our experience, it is much more common to have left portosystemic shunt than right. And because the left lobe of the liver is much more developed, the vessels are typically more dilated when there is a left portosystemic shunt than on the right side, as you see here. Again, this is another case of a right portosystemic shunt. You could see the significant anastomosis here and the dilation of the right hepatic vein draining into the IVC. Now, why these are important? Because there is some significant impact in many of those cases on the newborn. As you could see, these are the complications that could happen. There's abnormal hepatic circulation that promotes tumors within the liver. There is pulmonary hypertension because of the intestinal vasoactive mediators that are not cleared by the liver that go directly into the systemic circulation. And certainly there's encephalopathy because of raised ammonia levels in those fetuses. So there's some impact from these. So what are some of the poor prognostic factors? These are personal observations. When you have associated cardiac or extracardiac malformations, when there's significant fetal growth restriction or subjective decrease in normal portal venous system, and certainly increased flow in the hepatic arteries. Again, these are personal observations, not based on scientific data. Now, let me move into another vein that is important in the fetus, the left brachiocephalic vein. So in looking at the planes, the three vessel view, sliding up transversely, you get the ductal arch view. And then if you keep going up into the chest, in the mediastinum, above the pulmonary venous system and the ductal arch, you will see the brachiocephalic vein, and you see the aortic isthmus here. And certainly if you angle to the left side, you see the classic three vessel trachea view. So this is the plane that we're talking about, where you see the brachiocephalic vein here. Again, we are at a plane that is higher even than the aortic isthmus. And on grayscale, this is what you see. You see the left brachiocephalic vein bordering the thymus gland. And on color Doppler, you should see the clip that I just showed you with the brachiocephalic vein, with the blood going from the left side towards the IVC on the right side. What are some of the abnormal findings? So when it is absent, the left brachiocephalic vein, think about persistent left supravena cava. When it is dilated, think about supracardiac total anomalous venous return, or a vein of Galen aneurysm, or an AV malformation in the brain that increases blood flow. And there are some abnormal courses where it could be intrathymic, subaortic, retrotracheal, and I'll show you some examples. So let's talk briefly about a persistent left supravena cava, because it's a fairly common malformation, as you see right here. So here's an example of a persistent left supravena cava with the right supravena cava here. This is a pulmonary artery. This fetus has significant other abnormalities. But you see on color Doppler that the blood flow in the supravena cava and in the persistent left is in the same direction. Here you see the azygos and the hemiazygos draining blood into these vena cavas. So you see again here, right supravena cava, left supravena cava, same color, because the blood flow is going towards the heart, and absence of the brachiocephalic vein. Now, when you have a persistent left supravena cava, it typically drains into the coronary sinus. So you will have a dilated coronary sinus, as you see right here in this 4-chamber view. And as you see right here, looking at the base of the heart, you see under the 4-chamber view a significantly dilated coronary sinus, as you see right here. Now, you can have a persistent left supravena cava with an absent right supravena cava. Here, you will have an absent, for instance, here's another case of a persistent left supravena cava with an absent right supravena cava. Here you can have a right brachiocephalic vein, but I'm not going to go into the details of such malformation. So for you to know that the persistent left supravena cava is associated with a lot of congenital heart disease, and it's part of significant congenital heart disease, as you see right here. So keep that in mind, that when you see a persistent left supravena cava, even though it is normal in the majority of cases, it's really critical that you do a fetal echocardiogram to make sure you are not missing any other association. When it is dilated, the left brachiocephalic vein, as you see right here, as I mentioned, think about vein of Galen aneurysm. In vein of Galen aneurysm, as you see right here, you have a dilated venous system in the brain that increases drainage. You have dilated right atrium. Also, look at the carotid and jugular veins and how dilated they are. And then the brachiocephalic vein is dilated as a result of that. Another important feature in a dilated left brachiocephalic vein is a supracardiac total anomalous venous return. Here in a supracardiac total anomalous venous return, you have a dilated left brachiocephalic vein because the blood flow drains from the pulmonary venous system through a vertical vein into the left brachiocephalic vein and back to the heart. So if you see the schematic drawing here, you have the 4 pulmonary veins coming into a confluent vein, and then there's a vertical vein taking blood to the brachiocephalic vein coming back to the supravena cava. So now the brachiocephalic vein has an excess blood flow that is coming from the pulmonary venous system, and it's dilated as such. At the level of the 3-vessel trachea view, you have this extra vessel, which is right here at this plane. But note the importance of color Doppler, because the blood flow is in opposite direction to the supravena cava. Supravena cava blood flow is going towards the heart, whereas the vertical vein blood flow is going away from the heart. And that's really critical in your evaluation. There are additional features to suspect total anomalous pulmonary venous return. This will be discussed in another presentation, but suffice it to say there's increased blood flow to the right side of the heart. So the right side is dilated. There's a little bit of tricuspid regurg. There's more blood flow in the pulmonary artery as opposed to the aorta, and you see a discrepancy in size. If it is infracardiac, the IVC will be dilated. Supracardiac, as we've talked, the brachiocephalic vein will be dilated. Now, abnormal course of the left brachiocephalic vein, as I mentioned, absent in left supravena cava. And then when you have a persistent left supravena cava, as we mentioned before, we talked about the importance of looking at the coronary sinus to confirm that the coronary sinus is dilated where this vein drains. We talked about the vein of Galen aneurysm again, and I showed you the importance of a dilated left brachiocephalic vein. Now, Let's look at the course of the left brachiocephalic vein here. Typically, the course is bordering the thymus gland, as you see right here. And the direction of blood flow is always towards the supravena cava. So what you have here, again, is a normal plane of the left brachiocephalic vein, as you see right here, on the inside border of the thymus gland. You can have an intrathymic course of the left brachiocephalic vein, as you see here. So, and you see on color Doppler, this schematic drawing has the wrong color in it because the blood flow will be going towards the IVC. So it will be red here, as you see in this ultrasound images. And you see that the vein is in the middle of the thymus gland. And here's a clip of an intrathymic course of the left brachiocephalic vein. You can have it subaortic, where it goes under the aorta, as you see right here, to connect with the supravena cava. And you can have it as retrotracheal, where it goes behind the trachea to connect with the supravena cava, as you see here. You can have a double left brachiocephalic veins in rare conditions, as you see here. What is the importance of this? We have done a multi-center study looking at this. Here's the frequencies of the intrathymic and the course of the left brachiocephalic vein. When we followed those pregnancies, the outcome was normal. So this is just a normal variant of the course of the left brachiocephalic vein and should not have any risk factor to the fetus. When it's absent, however, you need to assess for the left persistent supravena cava and do a little bit more evaluation to assess. So I show you some important venous malformations. To summarize, the clues to diagnosis at the level of the liver, if you see dilated veins or you see any color aliasing that is not supposed to be there, think about the presence of venous malformations, whether it is whether it is a dilated umbilical vein, whether it is a portosystemic shunt or others. At the level of the pulmonary, there are several features that can suspect the presence of venous malformations, such as an increased retroatrial distance, the presence of a confluence vein behind the heart, and abnormal Doppler. And at the level of the left brachiocephalic vein, remember, it could be absent in persistent left supravena cava, dilated due to a supracardiac total anomalous venous return and a vein of Galen aneurysm, or an abnormal course, as I've shown you. The abnormal course is typically of no clinical significance. So hopefully I have shown you that the venous anomalies are common and significant. They're associated with major congenital heart disease. They can cause volume overload of the heart with high drops. They're associated with fetal growth restriction, with extracardiac and chromosomal abnormalities. Relying on a stepwise segmental approach may substantially improve detection of systemic and pulmonary venous malformations. I think it's really critical to understand and review the normal anatomy of the venous system. And from there, it is important to then understand, when you see some abnormalities, the significance of such. And a segmental approach is really helpful, that relies on the majority of these axial planes going from the abdomen into the upper chest, can allow you to review the anatomy of the venous system in more details. Thank you very much for your attention.
It was a very nice talk, and we are going to be very happy to have him. Oh, he's here. Good. Hi, Dr. Alfred. How are you? So good. Very nice talk.
Thank you. Thank you.
So we are going to have all of you together after the last talk to have discussion and answer the questions. But if you please, all the attendees can type their questions on the Q&A chat box, and we are going to be very happy to answer them for you during these presentations as well. So now we have Dr. James Huta, who is going to talk to us. He's the former chief of cardiology at CHOP and endowed chair of University of Florida. Thank you very much for joining us today, Dr. Huta.
Hey, thank you very much, Grace. Thanks to the Academy and the organizers. I know how much work you put into these, and just delighted to see the great participation you have, and there'll be others who will check in on the YouTube recording as well. And let me just say briefly to my co-presenters there that Alfred, after 40 years in pediatric cardiology, you taught me something new here today. It always happens every time.
That's an honor. That's an honor.
That's great. and just a very special lecture that Lisa gave. I think gorgeous, gorgeous presentation of assessing myocardial function.
Thank you, Jim.
Grace, are you ready for me to go ahead?
Yeah, you can share a screen. Thank you very much.
Here we go. Here we go. Well, it's a great pleasure to be with you here today and have a chance to update some data about the cardiovascular profile score, and also mention some pitfalls for those of you who use it every day. I'm sure you've encountered some of these, so this will be a chance to for me to give you some additional new information. Let me just take this opportunity, though, to say Merry Christmas to all those who are participating. We're here in Florida here, so there's no snow here, and it's going to be sunny today. I think by the end of the day, you probably know that it's snowing many other places here in the United States, and it's just really special to be part of this this terrific faculty. Let me say a special thank you to Rima Bader, my co-author, and Lisa, our book, The Handbook of Perinatal Cardiology. Now, let me take an opportunity to just do a short dedication of my talk today to Bill Norwood, who was Chief of Cardiac Surgery there at CHOP, and we worked together for 9 years, a colleague, a friend, and in that entire time, never a single sharp word between us. So special remembrance of Bill here today. I'll be mentioning the cardiovascular profile score for those of you who are new to it. Just briefly, it's a 10-point score with 2 points for each of 5 categories. We're going to mention high drops can have 2 points if there's skin edema. Venous Doppler, the most important criteria, and you've heard a beautiful description of these abnormalities that can occur in the ductus venosus and umbilical venous pulsations. The heart size, though, when it should be less than 1/3 of the area of the chest, and if it's greater than 1/3, but less than 1/2, there's a -1 point, and greater than 50% of the chest area, 2 points off. Now, I've added also the data from Jack Rychak at CHOP on the data with cystic adenomatoid malformation. When the heart is less than 20% of the size of the heart, of the chest rather, then we take 2 points off as well in that special circumstance because of the bad prognosis of that finding. Now, cardiac function, we refer to basically a 4-valve Doppler. Any holosystolic valve regurgitation of the AV valves or holodiastolic regurgitation of the semilunar valves would be a -0.0, and if 2 valves are involved, then 2 points off. In addition, we indicate the presence of monophasic filling, usually a late finding in cardiac failure. And then finally, absent end diastolic velocity in those patients who begin to have very low cardiac output may develop changes in the umbilical artery flows, or in cases of IUGR. But as I'll mention briefly today, IUGR is a special case where the cardiovascular profile score appears to be quite useful at predicting outcome. Now, just to review, this is the fetal congestive heart failure quiz today. So those of you we're supposed to have a multiple choice question. So the cardiovascular profile score consists of, and I'm hoping you'll remember these now that I've just gone over them. Number 1, heart rate, respiratory rate, cardiomegaly, hepatomegaly, or edema. High drops, venous Doppler, heart size, cardiac function, arterial Doppler, or jazz, blues, R&B, oldies, or Mexican drinking song. So you can indicate which is the correct answer there. While you're thinking about that, let me just mention that fetal cardiac heart failure is in contrast to neonatal and children's heart failure, which are indicated in the first option. So that the heart rate really doesn't change very much, even with a falling cardiac output in the fetus, and it's not one of our major markers for heart failure. This is one of the companies, your ultrasound companies, has included the cardiovascular profile score as a way to keep track of what's happening from exam to exam in patients who have abnormalities. Now, the use of the cardiovascular profile score, and as it was originally developed about 15, 20 years ago, was as a pre-hydropic marker for heart failure so that we can anticipate the onset of hydrops and provide treatment prior to skin edema and extensive placental edema occurring, so that medical therapy like digoxin couldn't get to the fetus if you wait too long or if you don't pick up on it early on. And then the other option or use of the score would be as a marker of the onset of falling cardiac output that results from the presence of hydrops. Now, the most common cause of hydrops that's non-cardiac would be viral infection. And as I'll show you in several large series, in fact, the hydrops prognosis where there's a viral infection involved is not nearly as bad as when there's a falling cardiac output as the cause. So these are some of the causes of fetal heart failure, and I'll mention that each one of these has now had at least one paper using the cardiovascular profile score to detect the presence of worsening prognosis. The fetal arrhythmias we'll mention as a special case, congenital heart disease, mainly AV valve regurgitation and myocardial dysfunction, some types of abnormalities. We'll talk about AV fistulas, where there's, for instance, the sacrococcygeal teratoma AV type of AV fistula, the twin transfusion. Now, though, since there is a very effective therapy, the cardiovascular profile score may seem to be very bad, but in fact can be dramatically reversed with selective laser therapy. And then, as I mentioned, hydrops is one where we want to know whether or not the score has points off for things other than just fluid collections, and in that case, the prognosis would be changing. Now, we know that heart failure affects about 5% of congenital heart disease patients in utero, and these common lesions are associated with severe tricuspid regurg or Epstein's, pulmonary valve regurgitation. And I won't be spending time on it today, but if you look in the literature, you'll find our modified cardiovascular profile score for the right heart lesions, where all the patients have a large heart and severe tricuspid regurg. And the question is, what are you going to use to follow those patients? And we found that the RV pressure estimate and the aortic velocity are the two key variables to use to follow those patients. Now, patients who have an AV canal type of valve and valve regurgitation can progress, and you'd like to know if they've had from study to study or from follow-up to follow-up, whether or not there's been any change. And this makes the use of the score in a standardized fashion quite useful. And then the patients with cardiomyopathy, I'll mention the data from the Toronto group in this regard. Now, this is a paper from Hofstadter on hydrops with the cardiovascular profile score, and showed that as the score got better, or rather as the patients got better after SPT was converted, for example, the score got better. As the patients got worse and those who were going to die, the score was useful in predicting outcome and prognosis. But the best predictor for any adverse outcome, as you probably are already aware, in almost any disease that you want to look at, is a falling cardiovascular profile score associated with abnormal venous finding. As Lisa showed so beautifully, signs of increased right atrial pressure or central venous pressure are reflected in the A reversal that happens in most diseases, not all, but in most, as there's stiffening of the veins and more transmission of the pressure waveforms all the way back to the umbilical vein. This particular longitudinal study showed that the cardiovascular score decreased a median of 1.5 points in those who died, who were followed with hydrops, and it increased in those who lived. Now, the validation of the score over the last 15 years, there have been 12 papers that have tested the cardiovascular profile score in these 10 different fetal conditions, and I won't go into all of those. I'll try to show you some examples, but I wanted to move on then to recent research that's been performed. This is a paper from 2019 that was published in on the obstetrical literature by Takikazu. And he showed that heart failure was defined as the cardiovascular profile score less than or equal to 7, and this is the key number to keep in your mind as you follow your patients. The serum concentrations of tumor necrosis factor, vascular endothelial growth factor D, and heparin binding epidermal growth factor like growth factor were independently associated with heart failure. So I like this kind of effort. This is similar to the work we did with Rosanen, where we looked at at the growth factors that were associated at birth in the umbilical cord and prognosis, and the score was correlated with the levels of these serum factors in the maternal serum in this case, and in the case of the Rossinen paper in the cord blood. So I think we're seeing now that there are signs in the circulation, humoral signs in the circulation, which is the major mediator, if you will, of signaling in the fetal circulation that there is a falling cardiac output. In addition, this paper appeared in 2017. This is from the group Aikida and also Takiyasu, and they showed that fetal heart failure, low birth weight, and primipara status were revealed to be the independent predictors of an urgent C-section due to intrapartium distress in congenital heart disease infants. Well, this is very important for fetal cardiologists. As we follow patients with congenital heart disease, it appears that the score can be useful in predicting and maybe at a marker in perinatal management planning. Now, let me hasten to say that perinatal cardiologists like myself are not obstetricians, so we don't tell you when to deliver a baby, but we want to give you good information about whether something is changing or not and what we should be ready for, which patient perhaps should have admission and more intensive testing and monitoring. So this is a teamwork with our perinatal colleagues, obviously. Now, let me just turn to some of the pitfalls that many of you may have encountered as you use the score on all kinds of different diseases. First of all, in those patients who have oligohydramnios, where the cord is being compressed for some reason or another, there is transmission of the umbilical artery pulsation to the vein. So we don't want to confuse that type of pulsation with the real umbilical venous pulsations, which have a timing that is from the atrial contraction. So they should occur before the arterial pulsation. And so this can lead to confusion, though, when there are what it appears to be pulsations, but in fact, they're just transmission of an arterial pulsation and have nothing to do. You might say, well, how can I tell the difference? Go back to the ductus venosus. If the ductus venosus is entirely normal and you're seeing vein pulsations, then almost certainly that they are not related to central venous pressure. Now, they're absent ductus venosus, you heard beautifully explained here today, where the umbilical vein will connect almost directly to the right atrium or to the inferior vena cava. Well, in that case, there is no ductus venosus in between the right atrial pressure and the umbilical vein and all the way out. And you may see intermittently pulsations that are transmitted back through this dilated umbilical vein. And I'll show you just one example of that in just a moment. So this is not a situation where you would want to take 2 points off for umbilical vein pulsations. In our experience, managing a patient like this, they would come and go. They were present sometimes and other times were not. If you go into the hepatic venous pathway, or even better yet, go to the superior vena cava, that's the place to look to see if there really are any abnormalities in the flow patterns in that kind of case. By the way, that case, which I'll show you, also had compression of the inferior vena cava to the point that the azygous vein was dilated and was redistributing flow through a dilated azygous vein in that particular circumstance. Now, in fetal tachycardia, obviously, when the heart rate is 250 beats per minute, you're going to see venous pulsations that are in the hepatic veins in all cases. And it doesn't mean that there's anything wrong with the central venous pressure. However, if this continues for a period of time, you'll notice that the flat umbilical vein will then begin to pulsate. The higher the central venous pressure becomes with prolonged fetal tachycardia. So we think it's useful in predicting whether the SVT has been going on for a long time or whether there's a rising central venous pressure, but not at the level of the ductus venosus or in the hepatic veins. And finally, in complete heart block, I'll make some specific comments about complete heart block because it can be an important lesion where you want to use the score. However, you can be confused in terms of diastolic regurgitation, which is low velocity regurgitation, and it happens intermittently, and it's not to be scored like AV valve, holosystolic AV valve regurgitation. By the same token, intermittent AV valve regurgitation is expected in complete heart block because of the AV discordance and the scanning of the atria and the ventricles and their relationship. So now and then you'll see a jet, and then other times you won't see a jet. We do not score that type of intermittent AV valve regurgitation. And finally, arterial pulsations in this lesion with a big slow heart rate and big stroke volumes are quite common in the umbilical vein. They're ventricular and they're not atrial. And we want to wait to take 2 points off until we see pulsations at the fast atrial rate in those lesions. Let's take one mention about AV fistulae. You saw the most beautiful example when Alfred showed you the example of the venous varix. The venous varix that he showed, those 2 or 3 examples, had a jet inside of them, which is due to an umbilical AV fistulae, one of the most common AV fistulae that we encounter. And in fact, unusually, but sometimes that fistulae will lead to heart failure. As he mentioned, you have to monitor the heart size. And in fact, these patients, if the score is 7 or less, are good candidates for digoxin therapy, which can be quite effective in lowering systemic resistance and improving their cardiac output. And finally, the area of cardiac area divided by thoracic area. Remember, I told you that it should be less than 0.35. And you might say, well, gee, what if the thoracic area for some reason is abnormally small? That would make your cardiac area over thoracic area ratio seem to be increased, and that would be a false increase in in what is an otherwise normal heart size. And so we use the biventricular outer dimension of the heart from epicardium to epicardium, and that should be about 1 millimeter per week of gestational age as a cross check to be sure that we're not seeing heart enlargement. Now here's that case I mentioned to you. There's a massively enlarged umbilical vein as it comes through the liver and enters into the heart here. In fact, it connects to the IVC very close to the heart here. And then there's a dilated azygos, as I mentioned. And so the venous pulsations that are present in the right atrium are going to tend to be transmitted back in a structure like this. And we would normally not score them because the venous changes are just part of the abnormal anatomy. And so to summarize, we look at hydrops. In our diagnosis of hydrops, you can have a pleural effusion and a pericardial effusion or even a little ascites and all just get 1 point off, and we don't take 2 points off until we see skin edema. That would be the one difference from the usual diagnosis of hydrops. Just a quick example, I did want to show you those abnormal venous pulsations, which are timed with the atrial contraction. This, by the way, is also another artifact. This is fetal breathing changes in the umbilical vein. AV valve regurgitation, we did not find in our prospective studies that the severity of the AV valve regurgitation had any correlation with outcome. So anything holosystolic we count as important. Here you see a case of cystic hygroma with very severe hydrops and late in gestation. Both valves were leaking very badly. And most AV valve regurgitation is not intrinsic valvular disease, a congenital malformation, but it's increased afterload and it's increased wall stress on the myocardium. Here's another case that is associated with heart failure, as you heard mentioned earlier, and that's the TET absent valve syndrome. This is the one that looks a little bit like a North Atlantic storm when you turn the color on, because you have this to and fro flow back and forth. And this diastolic jet into the right ventricle can lead to right ventricular dysfunction. So here the score can be very useful. And again, once the score is 7 or less, then we use digoxin therapy. You might, just for those who are interested, we usually use a low dose of digoxin, 0.25 milligrams twice a day orally in the mother. And most of those patients can be started as outpatients and don't have to be admitted for that type of therapy. Now, one other patient who presents with heart failure is the TET absent valve patient. And most of these don't have a ductus arteriosus, but I wanted to show you an example of a TET absent valve patient who has a wide open ductus arteriosus. Well, this is not a good thing when you have a severe pulmonary regurgitation associated with the ductus being open. You're going to have diastolic steal from the systemic circulation. As you can see here, there is marked regurgitation or bidirectional flow through the ductus arteriosus. And so as a result, we see diastolic reversal in the descending aorta, and this is the kind of Doppler marker we would use during our digoxin therapy to see if we're improving the circulation by improving the diastolic steal. We've actually used indomethacin on these patients with some success. Even constricting the ductus somewhat will decrease the amount of diastolic steal in the descending aorta. Just one other example of a congenital heart defect that could present with heart failure. The truncus patients will have regurgitation and stenosis at times, and the score can be quite useful in following them. So I think that this is the one article, our first article from 2007, where we looked at the score in congenital heart disease. Just wanted to remind you that the prognosis is not very bad if your score is 9 or if your score is 8. But when your score gets to 7, that's when we began seeing mortality in that group of patients. Those that need some more specific diagnosis. Specific management, as I mentioned before, the right heart diseases, especially those with tricuspid valve dysplasia. So let me make one other observation from the paper of Macacalio in IUGR, because I think this is very important for those cardiologists and perinatologists here. And this was shown very clearly that out of the 75 neonates with IUGR, all delivered alive, 8 of those died before discharge, and 2 of those had severe cerebral palsy. And those were the patients, those 8, in fact, who had abnormal cardiovascular profile score. So it looked like a prenatal cardiovascular profile score near term would be useful in predicting what was going to happen to those patients. And in fact, there was correlation with the 5-minute APGAR score, with the NT pro-ANP and pro-BNP cord blood levels, which correlated with the correlated inversely with the cardiovascular profile score. Here you see the ANP with decreasing levels toward normal score, and the same with the BNP in those who died. And so the cumulative survival, as you can see, with the cardiovascular profile score greater than 6, that is 7, 8, 9, or 10, there was survival in all, whereas less than the 7, there was mortality. Finally, let me show you one example, one of my favorite examples of an AV fistula, this time in the lung. This is a right lung arterial venous malformation. The patient has marked cardiomegaly, has a tricuspid valve regurgitation, and with the scoring, we would have 1 off for heart size, 1 off for valve regurgitation, and in fact, there was some fluid collection during some of the follow-up. We used digoxin in this patient, and there was improvement in the heart size. And then after birth, this patient, we were able to occlude the umbilical AV fistula using a catheter, and there have now been discussion about whether such a procedure could occur and could be done in utero. So this may pave the way for further interventions in transcatheter treatment of heart failure. So let me take this opportunity to thank those again who have invited me to be here with you. And again, it's a pleasure to be on such an august faculty. Thank you.
Thank you very much. It was very good talk. The 3 talks were very good. Even for me, a poor cardiac intensivist, I was able to understand. So this was very nice. So just now for our last speaker, it's going to be Dr. Rima, who is responsible for organizing this webinar. And I want to thank her again for that. And then after her talk, we are going to have time for questions and discussion. Thank you, Rima.
Thank you, Grace. I just want to thank Grace and Sasha for the great effort that they've been doing with this fantastic job. And fetal cardiology is very interesting, and I hope people get the love that we have as practicing fetal and perinatal cardiologists. I know that this has been a bit heavy with all the talks, so we're going to go into just interesting cases and trying to make life easy. This case is a 23-year-old prima gravida, 23 weeks gestation, referred for suspected cardiomegaly on routine anomaly scan. And as Dr. Hutakani said, where you take your area is very important, and if the thorax is small or big, and the relative size of the heart to the thorax is very important before you get your numbers. Now, this is how you do the area, and this is very important because just looking at the heart is not easy to give numbers, so we always advise to take numbers. So when they referred the baby, the fetus, there were no numbers. So this is what we're trying to go through, the basics of the fetal scan that we've done for this baby. And of course, we know that a 4-chamber is very important, and then you throw the color on once you have a proper black and white 2D, and you try to get the septum is very, very important to rule out small VSDs and stuff like that. And we recall that the area was normal, and you try to get a 3-vessel view as if you can from this view or other views, and you look here and you know that there is atrioventricular concordance, you see descending aorta, intact septum, and you look at the size of the atria and the ventricle, and you compare the right ventricle to the left ventricle, and you try and look at the pulmonary veins. Anyhow, it's not easy to say it's normal, but so far everything looks normal. Now also we try and use a 3D in a normal setup, and where you make sure that the septum is really well aligned, and then you try to get the outflow tracts and see the crossing, which is the normal. If we want to know that there's atrioventricular concordance, the second step is to go for the great vessels, the outflow tract, and see the relationships and the crossing. And then you try and play with a 3D and see if you can check the pulmonary veins. Of course, the post-processing is very important, and you throw the color on, make sure that you see the beautiful septum here, and you can check also the 2-vessel view and the flow and the color. Basically, the 3D is always based on a proper 2D view. And then you can do sort of like a scan and get a CT of the whole heart with different slices, and you put color on, and you try to see the RVOT and the LVOT and the 2 vessels, all based from the proper 4-chamber view. And you throw color and try and get the aorta and see the ductal arch, and then you also try and differentiate between ductal and aortic arch, and then you try and get the 3-vessel view, which is the pulmonary artery, aorta, and SVC. So we got all this, and so we thought that the baby was normal. And the second case is a 23-year-old Saudi lady, and always in Saudi, you try to get the ethnic background of the patients, and because we have a multi-ethnic society here, I always say, like in the US, different races, different ethnic backgrounds. And she was referred for fetal cardiac function evaluation in non-immune hydrops. And I always say it's very important to refer for function, as Lisa beautifully illustrated the value of fetal cardiac function in assessing the status of the fetus and prognostically as well. So, well, first of all, we have to make sure that this is really hydrops, and we know that hydrops mean that you have a fluid in 2 spaces, and you try and do, this is sort of 2D, 3D image, and you try and make sure that this is real hydrops. And of course, the etiology of the hydrops is different. Here, the hydrops was different. This one is fetal anemia, and the fetus hemoglobin was about 4. And this one was a different cause. So again, we try and do the 2D, and the 3D will help us to delineate whether there's just the fluid is around the heart, the lung, and also would like to see where the lungs are tagged and how compressed they are in assessing this. So that was a case of non-enduring hydrops, and of course you try and see the AV valve regurgitation, and this is very important. Postnatally, the value of AV valve regurgitation has a different meaning. If you do antenatally and you see any AV valve regurgitation, you are worried. So we don't expect to see any AV valve regurgitation, not as postnatal tricuspid valve could be normal. So once you see a regurgitation, you have, and this is very important in this core, because if you try to to know where you're standing. You look at the size, you look at the color, how much is the AV valve regurgitation, and then you do the Doppler and see if it's monophasic or biphasic. So the score helps here a lot. And I always think that the score is good. And it's a language that obstetricians and fetal-maternal specialists understand when we talk to them or when we write letters to them. Just to remind you of the book that we have out in Amazon, we are working on the second. Dr. Hornberger and Dr. Hoot and me were working the second edition, we say inshallah. Third case is a 30 years old Saudi midwife, gravida 2 para 1, 27 weeks, married to her first degree cousin, 30 years old, 32 years. And she was referred by MFM specialist to evaluate the fetal hydrops. Again, so first of all, we made sure that there's hydrops, and then we went into the umbilical artery and we looked at this. We were not very happy. Now, what we noticed here, and it was interesting, that there is a hyperechoic area in the ascending aorta, and the aorta, the flow was non-obstructed when you put the color on and try to see but it was really a hyperechoic, and this is, if you see it here. So that was the first thing that I've noticed, that why is there hyperechoic outflow tract? And then I went to the pulmonary and I found the pulmonary also was hyperechoic, and then I went into the aorta and I find a lot of calcification in the aorta there as well. So we were a bit worried, and we thought of one diagnosis with the hydrops. There was sort of what we thought of idiopathic infantile arterial calcification. And after 1 week of this echo, the baby was at IUFD, and it was delivered in this status. Of course, we've done whole sequencing for the baby and also for the parents, and still pending. This is for few counseling, specifically that the couple are cousins, third-degree cousins. Our case here is also a 35-year-old primary gravida referred for abnormal 4-chamber view and triplet IVF pregnancy. We're getting a lot of triplets and twins here in Saudi and in the Gulf and the Middle East because of the willingness to have a lot of babies. Also, that the IVF is gaining a lot of prestige here. So first of all, we want to make sure that this is a 4-chamber view, and we don't see a 4-chamber view. The easiest diagnosis antenatally is that when we see one ventricle big and the other one is not there, or as we call this single ventricle. And of course, you try as much as possible to see. You call it single ventricle. This is functional because anatomically, and if you do the post-D 3D processing, you will see a small ventricle. So this is as Dr. Anderson said, this is a physiologically single ventricle, but not anatomically, because there is another ventricle hiding posteriorly. So this is an easy diagnosis, and it's beautiful in 3D because you can go into the depth of the other ventricle and assess whether it's biventricular or univentricular repair. And another case here as well, in the 2D, where you see that this is an easy diagnosis when you see one ventricle, which is not apex forming, and this is the left ventricle, descending aorta and ascending aorta. So this, the whole spectrum of the left ventricle is a little bit smaller, and it's non-apex forming. And of course, the follow-up will show more worsening. And then when you do, also you find that there's also single ventricle physiology. So that was a diagnosis, single ventricle. Another case is a 47-year-old Saudi lady, gravida 8 para 6 plus 1, 23 weeks gestation, referred for abnormal fetal anomaly scan. And at that time, they did not do the first trimester scan or an NIPT. And she had an NT after the, probably at 14 weeks, if I recall. But it was abnormal as well. So what we see here, we see what we call atrioventricular septal defect, and we see a common atrioventricular valve, and we see here an atrial septum, and lower down there's a primum defect, and also try as much as possible to get the image without putting the color on, and you have to get a beautiful 2D before you get the color. And then when we do the color, we want to assess if there's AV valve regurgitation or not, because this will affect the counseling, and this will affect how often they come back for follow-up in the clinic, and with their chance of heart failure or not. We were a bit worried, a little bit worried, that one ventricle is smaller, but in the 2D it was not very sure. And when we've done the 3D, we could see that one ventricle is really smaller, and we could prove that this is an AV canal where there's a common AV valve and there's ostium primum. And this is the LVOT, the gooseneck or the unfolding of the LVOT we see in cardiac cath in cases of AV canals. And so the case was an AV canal. And this is also just to add to your flavor, another case of AV canal. And here you can see only one valve, and clearly it's a different morphology, but it is symmetrical. And then we put the 3D and we try and see the planes perpendicularly to each other and try and see if this is really balanced or unbalanced. And in this case, it was a bit unbalanced. This one is one case and this is another case. And this is a postnatal when you look at it and see what happens, and you have a clear, easy diagnosis of AV canal balanced. Another case, a 32-year-old have the 2-para-1. It's a school teacher, and here what the patient does is very important because of the frequency of visits, and if they can come and if they live near or live far is very important. And she was diagnosed by her MFM as Epstein anomaly. And so they wanted to make sure that this is an Epstein or not. And the 2D, you can see that the RV is really very muscular, and there is a TR, but we don't see what looks like an Epsteinoid valve in this view. I'm sorry, it's not beautiful, but this is what I have. And during the 3D, we can easily see that the RV is full of muscles, So if the inflow is okay, you have to check the outflow here. Make sure that the outflow is okay. So this is not a tricuspid valve abnormality per se. There's an outflow abnormality, and this was at that time. I'm sorry, I don't have the clip. It was well-developed pulmonary arteries, functional pulmonary atresia, and this was also the 3D of the tricuspid regurgitation, and the pressure was quite reasonable. Just for our junior staff to remind you, what is Epstein? It's a spectrum. It's very important to know it's a spectrum. And also we have to see the attachments of the tricuspid valve more towards the apex, and the severity of the score of the Epstein depends on how far, how deformed the tricuspid valve is. And also a little note to say that in most of the Epstein babies diagnosed antenatally do very badly postnatally. So the diagnosis is not an easy thing to do. This is the case. It has also postnatally, it was delivered, and it has pulmonary atresia, the BT shunt, and then total correction. And there was no problem with the coronaries in this case. Another case is a 23-year-old primary gravida Palestinian referred at 28 weeks gestation for abnormal mass in heart, and that when she went for the second trimester scan, the doctor the MFM was not happy, and there's a positive consanguinity, and this is her first baby. So here we saw what looks like a sheet of a hyperechoic area. Look at that one. So this is a function, looks okay. And then we look at the valves, and we look at what is this there. And of course, you have to know the anatomy, which is LV and which is RV, and which is the atria right and left. So we know that this is LV from the way we looked at it while we're doing the sweeps, and this RV. And then we look at the score. Can you imagine in this case, the score will be around 9, which is a bit scary, but it tells us that this baby will do well next visit and the visit after. So looking at the 3D of this baby, we find what looks like a sheet, looks like multiple masses, and there's a horror mass in the LVOT there, we're causing dynamic obstruction. So it's not a fixed obstruction antenatally, it was dynamic obstruction, and this is most probably a rhabdomyoma. And I got the beauty of taking a 3D. And we've done a review when I was with Lisa at Sick Kids, and then 85% of antenatal diagnosed babies with rhabdos developed tuberous sclerosis complex. And this baby delivered normally. So this is the value. The score was around 9. So we asked them to deliver the baby normally at full term. And baby actually, his APGAR scores were beautiful. And everybody was aware of this, and they was waiting. The surgeon said once we get abnormal vital signs, we'll take her. So in about 48 hours or less, the baby was taken to OR, and they took this off. And it was, of course, they cannot do anything about that. But this one, the pathology proved to be rhabdomyoma. Baby did well, as the usual story postnatally, and usually there is regression. But then you develop abnormalities in the brain and the skin and then development. Another case, 30-year-old Yemeni lady. So Yemen is in the south of Saudi, and refer abnormal heart rate on CTG. So looking at this one here, what we see is very fast heart rate in a 3D. And the beauty of the 3D, it tells you about the anatomy. And then we're looking at this one, we can easily see that there is 4 chambers. And this is a right ventricle. Offsetting of the tricuspid valve is more towards the apex. And so this is RV, and this is apex forming LV, and this is the left atrium. We don't say left atrium because of the pulmonary veins, but where the flap is opening, usually it's on the left side, and you have to see in a moving clip. And this is a descending aorta. And for God's mercy, that if you have arrhythmia, it's most probably normal structure of the heart. So this is a very fast heart rate, and there's probably supraventricular re-entry tachycardia as the commonest type of tachycardia. And we treat in utero, and we give big doses. And I know that the doses that we give is a bit scary for other cardiologists. It's usually up to 1 gram a day of digoxin, and you admit cases, and you either give IV loading or PO, and nowadays you give sotalol. Preferably sotalol is much better, but depending on the preference of the mother and where they are, and if you can monitor or not, you can choose whatever medicine you are trained to treat. So always a message here, when you see hydrops, was this baby, what is the cause of 9-minute hydrops? Did the arrhythmia end up with hydrops or not? So one of the causes is undetected fetal arrhythmias. And so far we don't have any halters that we send mothers at home with, as we do with kids, that they have halter monitoring to check the SVTs. Hopefully one day we will get that. So another case, and I'm not going to stay long. So this was also referred for a heart block. And this is also the beauty of 3D, that you see that more or less the anatomy is normal, but you can see that the rhythm is not good. Of course, this is not the way to assess any rhythm, but since we've done it, and then with the Doppler is the thing that you have to do, and you have to do SVC aorta or whatever, as Dr. Uti says, a complete ECG, SVC and aorta, where you have the PR and the QRS complexes. But anyhow, you have a blocked PSC, which is benign, and it usually recovers, and baby delivered normally. This is different from a premature atrial ectopics that you can easily see. And then in a premature atrial ectopics, then about 10% will go into fetal arrhythmia. You want to make sure that you don't miss that, and you time how many premature ectopics you get during the exam. And of course, you take proper history for caffeine, chocolate, and green tea, and whatever. So this is what they do for the fetal ECG, and Dr. Bettina Konyu and her colleagues doing a beautiful job. And hopefully one day we'll get a smaller machine to do fetal ECG all over the world. Now, a last case here is 38 years, Lebanese lady, gravida 3, para 2, referred for abnormal 3 vessel view. So the word, we have to talk about that, where they come from, because if they are visiting, or if they are staying for long, or if they go back home where they want to deliver. So it's very important that we take detailed history, gravity, and socially as well in our setup. So when we did the 2D and the 3D, we could easily see that there's dextrocardia, and also there is a big defect, and it was a tricuspid atresia with pulmonary atresia. Mother opted to go back home to get further confirmation and treatment, not in our setup. Sorry, do I have time, Grace?
Yes, dear. We'll have at least more 5 minutes,
Okay.
and then we start the discussion.
Okay, thank you. A 30-year-old Moroccan lady, gravida 5/1, gravida 32 gestation age, was referred for abnormal for chamber view. And what I saw here was this thing here, and this is the echogenic focus that we get a lot of referrals from obstetricians. I wouldn't say maternal fetal medicine, but from obstetricians, because this is a soft marker for trisomy 21. We usually don't ask them to come back, but when we do like in the 3D, we try to do like what looks like different cuts and call it TUI, and then you try and see where is this hyperechoic focus, and if it is one or more, and if it is really a focus or anything like with the first case with there's hyperechoic calcification in the outflow tracts. And so having different slices like CT will help you to see different, these are all at different angles at the views, and then you put color on and you try and see if there's obstruction caused by this hyperechoic focus or not. So usually it's benign, but being cautious is important, and we usually ask them not to come back to us, and most of the cases turned up to be normal. But if you have this focus in the setup of soft markers of trisomy 21, you really consider it seriously if the age and the parity and what you do with score and the serum markers that they do is abnormal. So this is usually in the context of abnormal trisomy 21. And of course, now people have a tendency to do an NIPT quite often, even at low indications. A 30-year-old Saudi lady, gravida 5/1, 32 gestations. They could not see the great vessels clearly. And I always thank our referring maternal fetal specialists or obstetricians or sonographers or residents if they refer, and I always say, please refer at the lowest indication. So looking at this one here, we could easily see that the aorta is anterior and the pulmonary artery is posterior. And so what we see here is transposition of great arteries. Now, if you see transposition of great arteries, you can, if you don't do the outflow tracts, and this is very important that if you do 4-chamber only, you get 60% of anatomical abnormalities. If you scan caudally towards the outflow tracts, you get about 90 to 93% detection rate of the anomalies. So here is where you can miss. If you have a normal 4-chamber view without doing the great vessels, you can easily miss. And then you look at the vessels and you see how they are being anterior. How do you know that this is aorta? You look and you see it's not bifurcating, and then you try and see this is another vessel there. This is the pulmonary, and you try and follow the bifurcation of the pulmonary. Of course, you know where you are, right and left, when you first start, and where is anterior and where is posterior. Looking at this, this is a beautiful outflow tracts that are not obstructed, which is very important. And you see the color here is very nice blue, and could be whatever, depending on the cuts that you're taking, but there's no outflow obstruction. This is very important in this case. And just to check that the foramen ovale, you have to check the foramen ovale flow in cases of transposition, very important, and see if they're restricted or not. And then usually antenatally, the shunt is right to left. So always in transposition, try and see if there's obstruction or no obstruction. And if there's any restriction of flow, you have to check the pulmonary veins as well antenatally. This is all very important in terms of counseling and where you're going to let the lady deliver, if it's a tertiary center, cardiac center, or wherever she's coming from. 20-year-old primary gravida referred at 23 weeks gestation, and there's a positive history of consanguinity, and early in pregnancy she had flu-like illness. I always say we tend not to ask a lot of history, and hopefully in the next copy of our perinatal and fetal and neonatal handbook, we are going to have in the appendix a big reference on how to take history sheets in fetal cardiology, because really, basically, as pediatricians, we need to take detailed history antenatally as well. So she had a flu-like illness antenatally, and then we noticed that she had what looks like mitral regurgitation in this case. And so she was just referred back with observation, and it turned up to be a parvo positive case, and antenatally everything was normal, and postnatally baby was doing very well as well. I just want to thank you for listening, and thank everybody for having the time to attend this beautiful webinar. Thank you.
Thank you, Rima. Thank you for organizing that. And now, guys, we're going to have a couple of questions for all the audience on the way of a poll. And I will ask the first one is from Lisa. Lisa, if you can read your question, and then we are going to ask everybody to answer, and then we can discuss the result.
Sure. So which of the following is true of all standard measures of fetal systolic function: shortening and ejection, long axis function, stroke volume? A, they're influenced by heart rate. B, are all impacted by preload and afterload. C, are all labor intensive. D, can be used for either the LV or RV or in complex CHD. And E, can be readily reproduced.
Okay, guys, let's answer some seconds, and then we are going to see the result. And Lisa, if you can comment on that.
I hope I picked the right one. No, I'm just kidding. It's a little early here.
Okay, let's take a look. That's what you were expecting?
Yeah. So all of these parameters are in fact affected by preload and afterload. So you always have to be cognizant of these measures when there is a setup of potentially high afterload, as an example, or potentially changes in preload, like you might see in an AV malformation, like some of the, both Jim and I think Alfred had presented cases like that.
Great. We have one more question. Next one. From Lisa as well.
So which of the following is or are true of speckle tracking to assess function of the fetal heart? Tracking may be limited by small size of the fetal heart, fast heart rate, variable scanning depths, and lack of ECG. Measurements made using different ultrasound equipment and software vendors are comparable. Speckle tracking with assessment of global and regional function can provide insight into the nuances of fetal heart function in different disease states. D, A, and C, or E, all of the above?
For a couple of seconds, and then we're going to close, and then you'll let us know if the answers are what you expected. Okay.
Great. So yes, it's tracking is limited. So it's A, limited by many different elements of a fetal scan. And as I showed you an example with Ebstein's and the single ventricle pathologies, it can provide some insight into how a normal healthy single ventricle adapts and what may be happening in the more severe end of the spectrum of Ebstein's. In contrast, the big problem that we see are measurements made using different ultrasound equipment, so different software vendors, are really not comparable. So you get numbers that don't entirely correlate with each other, which is where you have to be very, very cautious. Great. Nice job.
Okay. Amazing. Now we have 2 more questions. Dr. Alfred, can you read your questions to the audience?
Sure. See it first. blood supply to the fetal liver is mostly from which vessel? Hepatic artery, main portal vein, inferior vena cava, umbilical vein.
It was a very clear presentation. Let's see what people is going to answer. And thanks again to all of you for being with us. Almost Christmas, we know this time of the year is very busy, so we are very, very happy to have all of you. So let's see the results.
Actually, this is the fetal liver, so it is the umbilical vein, right? The umbilical vein is the main supply of blood to the liver. As it comes in, connects with the left portal vein, and then provides the most blood supply to the liver. The hepatic artery only gives about 25% or even less. Postnatally, in the adults, the main portal vein is the main blood supply to the liver.
Okay, so this
tricky,
is like a board question.
But it was close.
It's like a question, you know?
Yeah, it's a board question, yeah.
Yes. So let's see another question.
Persistent left supravena cava is associated with which of the following? Dilated brachiocephalic vein, normal sized coronary sinus, absent brachiocephalic vein, or interrupted inferior vena cava. Maybe it should say most commonly associated with.
Okay, let's take a look what people are answering. This I think I know as well. Let's see.
Okay, correct. So it's the left brachiocephalic vein will be absent because in the greatest majority will go to the coronary sinus. So the coronary sinus will be dilated. So the brachiocephalic vein will not be dilated in this situation. And there may be some interrupted IVC, but that's a very rare association.
Great. We have a lot of nice questions on the Q&A, the chat box, and I think it's going to be a good start for our discussion. To start with, Marina Zamet, she is a fetal cardiologist from Brazil, a very close friend of mine. She typed some questions on the Q&A, and I invited her to make her questions live to you. Welcome, Marina. Very nice to see you. Thank you.
Thank you, Grace. And first of all, thanks, Grace, Sasha, and Gil for all these years, excellent webinars. And I have two questions, one question to Lisa, another one to Professor Yuta. Hi, Lisa. We met each other at the beginning of this year in Dante Pazanese. And Lisa, I'd like to know in a fetus with diaphragmatic hernia, which measurement do you think is the best one to do to evaluate the left ventricle function? And if this strain is a good idea to evaluate the left ventricle in the future, as we have a compressed ventricle by the abdominal viscera. And the second question is to Professor Yuta, is just to know if, since we have this new evaluation of these new techniques and evaluation of fetal cardiac function, if someday we will incorporate some of them to the CVP score to be more reasonable. Thank you. Thank you.
Hi, nice to see you. So the first question, so you're right. I think that there's redistribution and there's data to suggest that there's redistribution of flow related to compression. I think strain's probably going to be reduced because it's underloaded. And also, to be honest, the actual squeeze of the heart is usually not so impacted in the context of CDH. I think right CDHs get into trouble because there may be distortion of systemic venous connections and even umbilical vein. I don't tend to routinely do a lot of cardiac function assessment outside of the basics because that's what we do for everyone. But don't tend to use anything of higher, more sophisticated assessments. I think for the most part, they have relatively normal function. It's unusual to develop hydrops other than maybe the bad right-sided ones, but that's probably related to other issues and not cardiac function per se.
Okay.
Yeah, if I could just follow up as a comment, we believe that the direction of the IVC blood is deviated away from the fossa ovalis by the deviation of the atrial septum to the right. And that's one of the reasons there's so much redistribution, so-called smallness of the LV. And so we don't really like the idea that it's compressed at all. It doesn't make a lot of sense.
Okay.
If I may ask, Dr. Hutter, what do you mean by that? If it is the redistribution, how would you detect it? What made you think of it?
Well, the RV is big and the LV is small, so that the flow is staying in the right side of the heart rather than passing to the left in the normal fashion, because that kind of normal pathway is interrupted by the change in the angle, if you will, or the change in the accessibility of the fossa ovalis. So
just redistribution, but no affection of function, right?
Right. I think I would agree with Lisa in that regard. We spend our time looking at the pulmonary arteries and doing oxygen tests and stuff like that, but not much in the way of function.
And like I said, the right ones are ones that get into trouble. I think are more often get into trouble, and I think that's more because of distortion of the systemic veins. And
especially if they're premature, right? They're less than 1 kilograms with diaphragmatic hernia. I think probably that will affect the function. Lisa?
Yeah, I don't know. I mean, if there's placental insufficiency, you can get cardiac myocardial pathology, but yeah.
Okay, thank you.
Nice.
Let me just go ahead and answer Marina's question. And nice to see you. Good morning. We haven't met before, but the cardiovascular profile score, when we first developed it, actually we did a large series, including tissue Doppler and including tie indices, and we just couldn't find any reason to include it in the score. And I think the reason is that it does go off in the late cases of low cardiac output, but by that time, you have high drops and you've kind of missed the boat. And really, the score was designed to be a very early detection tool to be to screen for falling cardiac output and to follow those patients. And I will say, though, our fetal lamb experiment, some of that's been published in the American Journal of Physiology, where we looked at E prime in the progressively acidotic lamb fetus, showed that E prime did go down. There's no question that that diastolic function will go off early and severely in severe hypoxemia and acidosis. But I think those are late findings. So we tried to include it, but we didn't because it didn't fall out in our work.
Okay. Thank you.
Rima, if you want to take a look on the Q&A chat box and make the questions for the panelists.
Lots of questions myself.
Take a look at what you think is interesting to be answered live.
This is Amber Agarwal. Is umbilical vein cannulation safe in neonatal period in cases of port-2 systemic shunt? I think this goes to Dr. Abu Hamid. Is umbilical vein cannulation safe in neonatal period in cases of port-2 systemic shunt?
Yeah, so I usually don't take care of neonates. As soon as the shoulders are out, we wait for the placenta and move on. But I would anticipate it should be safe. The only risk I would say to make sure that the cannula doesn't follow the path of least resistance and end up in the left portal vein if there is if the vessel is of such size. But I don't think there's any reason why it would not be safe.
Lisa, what do you think, and Dr. Hutter? If there is abnormality in the venous system antenatally, is it safe to do the umbilical vein cannulation?
I suspect it's happened many, many times, and people have just not been aware. I don't have any data for if it's actually dangerous, but I'm sure that's been the case because there have been many cases we've seen over the years, and they've not been discovered, unfortunately, prenatally.
I'm not sure that would be dangerous, but I do want to mention one case of venous varic, so-called umbilical AV fistula, that if you put an artery and venous lines in those patients, both will wind up in the liver, passing through the AV fistula. So that kind of nails that diagnosis, a diagnosis we didn't even know existed before fetal evaluation.
So anything will happen if it goes into the liver. Probably they do an X-ray and find that it's really going to.
Yeah, that's exactly right.
So they put it backward. Another question to Dr. Huta: what are the signs that led you to think of congestive heart failure in a fetus?
Well, I think sometimes the referral will be a large heart. You'll be looking, or they'll see, obviously sometimes it's hydrops, but more often it would be, oh, we're seeing some valve regurg that we didn't, because it's never normal to have holosystolic valve regurgitation. And then I think a large heart would be probably the most common referral reason. And I think the twins are of interest, because following them and finding early findings of change in the larger twin is useful.
I always I learned this from you, but I don't think people take it easy. When you in the score give a -2 to hydrops, because everybody thinks that hydrops is bad, and you say, no, I give -2 for hydrops.
Yeah.
And
well, I think the point here is there are two kinds of hydrops. You've got the cardiac related hydrops, where you get the -2 with skin edema, and then there's nothing else. You can't find anything else in the circulation that's abnormal. That's going to be most likely to be viral and have a pretty good prognosis. If you have associated cardiac markers and the score is falling down, then I think you refer you to that, paper that came from Berlin, or from the group rather in Munich, and that was pretty clear that there was that group of patients who are not all going to die with hydrops. But again, this is maybe a question for Alfred. What do you see?
I mean, it really depends on the cause, right? I mean, many patients with hydrops, now we know there's an ongoing study at UCSF looking at genetic screening, that a lot of them have some genetic cause for it that we did not know of before. Maybe about 20%, I think, of idiopathic hydrops, if I recall, have some associated genetics that is picked up by whole genome sequencing and whole exome sequencing. So there are certainly several that we don't know of. There's some that are metabolic causes. So maybe half of hydrops are not related to cardiovascular issues, really. So they're related to other things. So.
Yeah, I think we know that hydrops, however, because of its direct effect on vessels, can lead to a falling cardiac output. So that's where we would use the score to screen for changes that might be secondary to hydrops.
Also, hydrops prognosis, not just the score, it's the gestation, right? If it comes early and if the score is okay, this is also not good. It's good at the time, but it will not make it till term.
I mean, in general, hydrops without an identifiable cause that could be reversed is a poor outcome in general, and certainly if it's at earlier gestation.
Grace, you want to carry on with the questions?
There's one very interesting question that Adrian made. We have been having a series of webinars from Dr. Anderson about morphology and development of the heart, and Adrian is always with us, and he's asking, is there good evidence today for the form follows flow theory?
Certainly, we've all had cases of critical outflow obstruction that start with a big heart that goes to a small heart, and all the way back from the late 90s, not even the late 90s, but the early 90s, that was recognized. Maybe even the late 80s, that was recognized. We've also had cases where there's been primary myocardial disease, primarily impacting one side and not the other, where there's dysfunction, a progressive reduction in flow, resulting in an evolution of a small left heart or a small right heart in that context. I think obviously flow impacts form also impacts flow. So you have it both ways. I think, yeah.
One question to Lisa about counseling in cases of hypoplastic left heart syndrome. Counseling the parents. How would you counsel them?
Oh, that's a long discussion. Obviously presenting the findings and explaining to them a little bit about, the severity of the disease. I usually also, when they're as a prenatal diagnosis, we would talk about extracardiac associations, including chromosomal anomalies. risks, those sort of risks, and encourage thinking about having genetic testing. We talk about progression, which for most of them there isn't big progression, but we've had a few develop RV dysfunction and TR late. We've also had quite a few develop restrictive atrial septal defect, which is problematic for the baby right at birth and changes the way we treat them in the immediate with the immediate delivery and managing a restrictive atrial septum with the septoplasty or stent placement. And then we talk about the sort of approach that we have clinically after birth with respect to single ventricle palliation. For most, we would offer that. We do occasional hybrids as our first stage. Mostly, though, we do Norwoods. And I will always tell them those risks of those procedures, the risks of interim losses, that this is not an easy course and has a long-term guarded prognosis. With some of our patients, if not eventually all of our patients, needing a transplant.
Yeah, we always put the transplant as an option, right, when in counseling, as
we don't offer it up front as an option. We still are using the kids' hearts through palliation, but we would. But I would definitely say I don't think those RVs function well long term. And certainly even in teenage years, as you see, the kids look great early on. And in teenage years, you start to really see that RV not looking very happy. And you can imagine getting out another 20, 30 years is probably not going to happen with that heart. I would be very, very worried. And Jim, you've had even more experience than me in this area, but we're pretty frank. Certainly we would tell them they have an option of pregnancy termination, which I know isn't true everywhere in the world in every jurisdiction, but that's something that we still very much offer. Semi-controversial is the offering of palliative care or compassionate care at birth. And I still do it. I don't push it because my colleagues don't feel 100% comfortable, but I think if a family really don't want active treatment, and we've seen that a few times over the years, that is something we would still potentially offer. I think the hard thing for families, though, is when the babies come out and they look so beautiful, it's very hard to stick with that choice. And I warn them of that as well.
Lisa, I agree with everything you've said. One other thing that we offer is we give all mothers who are carrying babies with hypoplastic left heart syndrome a sheet of the polyphenol containing foods to avoid in the third trimester. We believe that those rare cases that develop RV dysfunction, tricuspid regurgitation, are due to ductal constriction from the mother's dietary intake. And so that's something we offer. I'd refer you guys to Paolo Zielinski's beautiful work, but we'd be glad to share that sheet that we give, the foods that we ask them to
We'll put it in the handbook. We'll put it in the appendix in the handbook.
Yep.
We have
one question to Lisa regarding the hypoplast. How would you assess the function of the single ventricle? Now, we want to know if this is going to be biventricular or single ventricular repair. Can we say that antenatally with assessment of function? Can we?
I don't know of any data that does that. So you're saying kind of the borderline left hearts, not the frank hypoplast. I mean, frank hypoplast, we look at inflow Dopplers, and we know that they typically have an A-wave dominant inflow. And we usually look at squeeze. Do we do more? We've been progressively collecting data with TDI and with the ability to go back and do strain and stuff. I don't know for borderline left hearts. I don't know that there's clear data that any specific measure of function can distinguish between those that will require single ventricle palliation versus those that don't. We have a paper coming out in Ultrasound Obstetrics and Gynecology shortly, though, on borderline left hearts. And actually, the majority of ours have ended up down 2 ventricle route. So often you think that the left heart's much worse than it is. Postnatally, we usually sit them on prostans and wait a few days, let their left heart kind of get bigger with better preload. And for most of them, they end up going down a 2 ventricle route. So I know that kind of took us off course, but.
No, my question was, if there is a single ventricle, will the function tell us if it's RV single or RV or LV single? Can the function tell us if it's going to be a systemic ventricle in the future or not? I'm just trying to think of because you want to know if this is, we know that the RV fontans do worse than the LV fontans postnatally. Can we predict this antenatally? the function.
I don't know that I'm not sure that anyone has done that. I know there's work in newborns preoperatively and predicting how that ventricle is going to function long term. I don't know that it has actually been done as a fetus. We're currently looking at that because we have data in about 35 hypoplasts that we've looked from late fetal stages. And even have data earlier, but we were starting with late fetal through the perinatal transition to say, look with the acute changes and sort of demands of the heart during that perinatal transition leading up to surgery. Is there something that could be predictive? We'll have some prenatal data there. And for most of them, we also have mid-trimester exams, but we're not yet there. I don't know, Jim, do you know of any data along that line?
Well, we looked early on comparing right and left ventricles, single right and left ventricles, and found tie index differences, but we've never published them.
Yeah, it's very interesting also what Lisa said, that the tie index is gestation dependent.
It's a little mix of the literature, and the numbers aren't all exactly the same from one study to the next. Plus, some of them, they use tissue Doppler data as opposed to pulse Doppler data, so, as opposed to flow and pulse Doppler data. So you have to really look at that. All I can say is the number that we typically use is a less than 0.45. And very early in gestation, it's very, very high because of ICT and IRT or IBR, the isovocal contraction and relaxation times being very long, as Jim published actually years ago.
Okay, we need to move to the end of the session, unfortunately, but we have still time for a couple of few questions. There's one question from the audience, still talking about hypoplast. What is the experience of you with interventions for this disease, fetal interventions?
Well, we don't have a fetal interventional program, but we've certainly offered interventions and had second opinions from Wayne and his group in Boston, and evolving experience in Toronto. We've also reached out to Greg Ryan and Edgar Yegi on cases. I'm probably a little biased because our outcomes have not been fantastic. I know that there's published data out there, so that where there are successes. I was just involved with another meeting not that long ago, NeoHeart out of Columbia University. And one of the comments to Wayne, who was on the panel, was, well, how many fetal intervention programs do you think, cardiac intervention programs, are really necessary in the US, given that the number of patients for whom it actually is probably most appropriate is smaller and smaller and smaller as they're honing in on those in whom there's going to be a successful two-ventricle outcome. And the question specifically was, do you think there's room for more than one or two centers? And he actually himself said no. that the numbers are, I think that there's definitely room for fetal cardiac intervention for certain patients with critical aortic outflow obstruction, some with critical pulmonary outflow tract obstruction, some who are developing hydrops because of poor left or right heart function. But the numbers are relatively small.
Oh, happy day. Oh, happy day. Thank you. Oh, happy day.
That's so sad.
Jesus was.
Does that mean we go, right?
Jesus was. When Jesus was. He washed my sins away.
Can you hear me?
Yes.
Oh, yes.
Yes, no, the idea was 2020 was a very strange year. This make a lot of change in life. But on the other side, I don't think that Jesus was. We all together
Jesus was.
I think that
My Jesus was.
but the new way is not so bad. We are able to
Now I can't hear anymore.
Is it okay now?
No, only the music.
Okay, now?
Now I can hear you.
So again, what a a strange 2020, and I think that this was a new amazing opportunity to meet all of you, to share experience, to join. You can see from the chat, we have people from all around the world at the same time, in the same place, trying to improve the level of assistance for patients, for congenital heart patients, for patients with for neonates and newborns. And we really appreciate this enormous job coming from Gil, Grace, and all of you, because you spend your time. I'm sure you are tired. We are experiencing webinar fatigue. That is something that is growing, but it's something that we cannot say without, because now we want to know every day from different parts of the world. So thanks from deep of my heart from Italy, and we suffer a lot the COVID period. We are very happy now to experience the vax, despite some stupid people all around the world that doesn't accept vax for this disease. We are lucky people. There are people that will never reach a world conference. They will never reach a conference. And I'm sure we are trying to help them in this moment. So thanks to everybody. And
thank you, everybody. Stay safe. Bye-bye.
Thank you. Thanks for inviting us.
Bye-bye.
Thank you, guys. It was an amazing year.
When Jesus was, when Jesus was, when Jesus was, when Jesus was, well, my Jesus was, when Jesus was, he washed my sins.